cleft palate patient of orthopedics, and orthodontics is obviously the lack of alveolar bone in the misshapen jaw. So let's see how we go through this. So the main challenges, we've got the misplaced and displaced teeth, the impacted teeth, transposed teeth, missing teeth, extra teeth, misshapen teeth. This is a big one, the lack of attached gingiva from previous surgical closures, and then the scar tissue, and we had a lot of discussion on scar tissue and soft tissue this morning, and I think that doesn't get enough fanfare. Part of the things I've heard the last couple of days here, that just from the orthodontic perspective, and just mentioned, they have me down as an MD in the program. It is DDS, and I'm the only DDS on the program, so I feel the weight of my whole profession here. But anyway, a couple of things from the dental perspective. There was a discussion yesterday, which I figured I'd wait till today, but unfortunately, I know people had to catch flights and aren't here, about 50% failure rate of implants into grafted bone sites. And I was just sitting there going, why would you even attempt to put a dental implant into a grafted bone site? I think that's ludicrous. I just think that is just, and then the 50% failure rate you heard about is just, I think, just speaks volumes. I mean, failure rate in implants in general is less than 1% failure. And all of a sudden, and that just tells you, traditional bridge work, again, this is that generation, faded away. I mean, when I went to dental school, we were taught with traditional bridge work. This is what you need for that missing lateral incisor. You're seeing another way to handle it here than what I'm going to present. But anyway, and then the soft tissue and surgical relapse and that tissue drying it back, those VSPs, they're great, they're fantastic, but they don't take into account that after bones are placed and sutured in place, that soft tissue and the scar tissue is going to relapse those bones and teeth a little bit. And we deal with this all the time orthodontically. And sometimes we can recover from it, and sometimes we can't. So still, the challenges for us as orthodontists continue. Again, that's what I just alluded to, the movement after surgery, that those scuffed bones just don't stay there. And then failure of alveolar bone grafts we have to deal with, which we're going to see. Sometimes these sites fracture while you're trying to move the jaw during the surgery. Don't always get a clean break where you want them, and then we have that to deal with, the breaks between teeth that weren't intended to be there. And some of these kids, we have a lack of oral hygiene, which leads to bad tissue, and as everyone knows, you can't suture that inflamed tissue, and some of it's just ownership, they're sick of dealing with doctors, they're sick of dealing with dentists, they're sick of coming to orthodontists all the time. And this is how these kids react psychologically at times. But our main challenge is I've got to take that and turn it into something normal where a jaw can be moved and then fit with the other jaw. And this patient you saw yesterday, that Dr. Rampazzo demonstrated with this young lady, parents, military. I apologize if I'm talking fast. I got about 4 hours of material. I've tried to cram into 10 minutes, so I apologize if I'm talking like an auctioneer out here. So anyway, she's had several failed surgeries, and now we've got to get that fistula closed and get her into a situation where she can have orthodontics and get, so here's how I started it. I don't use a lot of coagulants, but this was a good indication for it. And then we start with some braces and just start gently moving these teeth out with segmented wires. And she actually had a canine, and I did not remove her. She had a deciduous canine that had a good root, but bad tucked away. There was a permanent canine, and we had this uncovered. And we just gently start to bring this out. And again, military family, they've moved twice since we started with her in my office, and they continue to come back. Now they're in their dad station in Fort Knox, Kentucky, and they still come back with these 6-7 hour drive to see me and to see Dr. Rampazzo. Still a work in progress. But here's where I got it. It took 2.5 years, but we got it back to more of a normalcy so we can do the skin graft and the bone graft, the pre-flaps that you saw yesterday. So anyway, the goal is to get those teeth in a proper dental occlusion, so after the jaws are positioned, they're going to fit. So normal orthodontics, I'm trying progressively every visit to get the teeth to fit. This is a little bit different. I'm not worried about their present occlusion as we move. So sometimes out now in the hospital setting, it's a lot easier. Most people have orthodontists they're working with regularly and regular communication, and I know between me and Antonio Bahar, we're like texting constantly on patients. And I know a lot of you probably have that relationship with orthodontists on your team, but your plain orthodontic patients that come in, you don't quite have that level of communication. I recommend sending them a letter or email and tell the orthodontist exactly what you want. I want these teeth moved, I want these teeth out of the way, I'm going to have to put an incision through the bone in a certain spot. So let them know what you want. The other thing I would say, and I was glad to see on the slides from USC this morning, that there were bands on the molars. Tell the orthodontist, because out in the community now you get these bonded molars, and it's tough to do surgery when you've got those bonds on. Tell them you want the bands, and tell them you want those second molars bonded. Don't be afraid to tell these people. Tell them, okay? Because too much of this out in the community orthodontics doesn't happen. But these patients got that one chance at orthodontic surgery, so make sure you're getting what you need. All right, the other thing, what orthodontists all wish surgeons knew, particularly not the DDS MD surgeons, but MD surgeons, is respect the attached gingiva. Respect that keratinized gingiva, because that's what we need for tooth movement. We need keratinized tissue. What does it look like? All right, so just to review first year dental student material, we need that keratinized gingiva. We need that. That is the basis of where we need to move teeth and health of teeth and the alveolar. All right, so first, this actually dovetails nicely with some of the stuff we saw this morning. So this was my worst class 3 ever, so I just thought I'd put it in there very briefly, and there's what we got into. Now, the interesting thing about this gentleman, I've been practicing 27 years, and here's his before and after step, but in 27 years, 2 setbacks. So with what Dr. Buckman was saying is bring the maxilla out. I am a big advocate of don't do setbacks unless you have to. I realize syndromic patients way different, but you're going to get a much better face just advancing maxillas as opposed to, even if you feel you're over-advancing them, they're going to look better in the long run rather than setting back mandibles. Less airway problems too down the road. How about class 2s? So again, just your garden variety condylar degeneration, and here he was. This is the one that always stumps the residents I teach as to how did this happen surgically. I'm sure I'm not stumping anybody in this room that we did the condylar implants for him. All right, let's get to cleft. So this young lady was referred to me 7 years, 0 months. You can see she's still got a pretty large palatal fistula, and you can see all the scars. We expanded her, and as you see, there's nothing in there. So she went through a lot. All right. So then she had the bone graft with the buccal flap, then the revision with the tongue flap, then a pharyngoplasty, then a revision. Another failure of the bone graft, scar tissue revision, the pharyngoplasty. So she's in the plastic surgeon's office all the time. Nothing's going well for this young lady. Let's just fast forward the clock because of our 10 minutes. So here we are, and there she is. So we've got, that is actually where her 2 centrals were, that far off. And here's the issues we have to deal with orthodontically. So I've got this big cleft with no bone. She had the tongue flap placed, so we've got the tongue flap. And again, when you need attached gingiva to move teeth, there's no place to move teeth here. I've got retained deciduous teeth, the cross-site, the central's way off the midline. And then there's, as we go, and there's a picture of what her lip and nose looked like at the time. And so then as we get inside, now we've got what we call transposition. Okay, the canine and premolar are out of whack. Now the inclination is get the premolar out of there. This is if it was your garden variety ortho patient, transpositions do happen. What do? Well, we remove bicuspids. Because getting the canine where it needs to go is a critical situation. So here's what it looked like on the CT we ordered. And we start to see, you can see the cleft, but then you start to see supernumerary teeth, deformed teeth, everything imaginable. So here we got the close-up of that. Here we got from the one side. You see we got barely any bone around the center. She does have, it's just a mess, another little supernumerary that creeped in. All right, so where are we with this young lady? She's 14 years old. She's already had 16 surgeries. She's in the 8th grade. All right, so first I sent her off to the periodontist. Let's get some catch gingiva. Let's see what we can do about reducing that tongue flap. He said we can do it. There is still fistulas under that tongue flap that he determined by using his little probe. And then, but he said we can do it, and let's get the surgery going as well. We can visit some of this stuff. Consulted with the oral surgeon about the canine. Now we still have no bone there. What are we going to do? We can't expose that canine and bring in no bone. So this is, I think this was about, because I was, again, very, we had the conversation on BMP yesterday. So this was, if I remember correctly, this is probably about 2010. So we're going back about 8 years on this. So we decided to use a BMP. It was not that, it was fairly new at the time of using that in this category. So we decided to use the BMP and try to create some bone and stimulate it as we bring the tooth down. All right, so then we expanded the jaw, got the braces on, exposed the canine, got rid of the supernumeraries, the cake tooth. So here we are with the RPE in place, and now she's 15 and a half. And there's first thing notice there is no underbite, and there's our canine way up there. Here we are, we still got the supernumerary in place, as you see, and there we are with the exposure chain on. The BMP's been put in place, and we've got a bunch of the Ks, the supernumeraries are gone, and now I'm gently bringing this tooth down, and you can start to see we do have some bone forming around that tooth root as we go. Here's 5 months, we have a little bit of bone, I would call it great. And then here we are 13 months post-exposure, and you see we're not so good. And here we are at 20, and we still have a cleft on her, and here we're backtrack a year here. And you see underbite, so even though she was 16 without one, don't think you're out of the woods. Here she's 19 with one. Took a hand wrist, her growth is done. Here's some pictures. So here's what we got. We got quite a long ways orthodontically to get that normalization of dental arch. And here's how I started to handle that transition. A natural tooth root is better than anything else we have. End of story. If you have a natural tooth root, it is better than anything else. So here we are, ready for orthognathics. There she is after, I'll look back one, there she is after the orthognathics. You can see the better lip contour and how everything looks way better already. And occlusion, really nice. And again, the bands on the molars, you see we still have that tongue in place. And again, tell that orthodontist you want those molars banded and you want those second molars leveled with the rest. Here we are, braces off. Got the midline on. Okay, and there's her teeth. We're not done. That's still, we're only halfway home, or maybe 80%. There we are. And there's her post-treatment stuff. Now, because of the weakness during the surgery, she was plated across the previous cleft site. All right, so now we went to the periodontist. Now we need to get that catch gingiva situation addressed, the tongue flap addressed. Another year and a half later, there we are. And now we've got that tongue graft reduced. Here we are 2 more years. Now you see the rhino's been done. Now, the prosthodontist, we have a very talented prosthodontist in Cleveland who I use a lot. So now you see he reduced that bicuspid into a premolar. And then we are before and after from where I first met her. And then before we actually started the definitive stage of orthodontics and surgery. And there her teeth are now. So there was more periosurgery we had. You see a graft in there, free gingival graft. So summary on her. So she had 4 plastic surgeons, 4 ENTs, 2 periodontists, 1 endodontist, 1 prosthodontist, 1 pediatric dentist, 1 family dentist, 1 oral surgeon, and the one person who was with her throughout the 20 years you saw there was truly. So I always say thank you to your orthodontists. We're the ones that have these patients like essentially from birth till they're done with college. So she had this so what these patients go through when we see them from birth on, 25 at least. I've lost count at some point. Now this is just my office again, and somebody mentioned yesterday about being cautious with radiation dose. I am very cautious, particularly in my cleft patients, on the radiation dose. And still, even with my caution, that in my office alone, 4 to 10 cephs were taken on a Visual Machine Plus. We had 3 CBCTs ordered, and I don't know how many more x-rays were taken in the course of at hospitals and other dentist offices. So she's had a huge radiation dose for a young person, and she still has a nose and lip revision planned for this fall. So thank you.
Our next speaker is Alex Lynn, distract cleft patients.
This is the advanced problem. Thank you very much to the American Society of Maxillofacial Surgeons, Dr. Frank Pepe, Dr. Rucazzo, and Gerard, everyone at Cleveland Clinic for hosting this. And thank you for all of you being here. I have no relevant disclosures, and we all know about cleft lip and palate, and it's really not just the soft tissue. The problem is the bone, because the problem is the disease is mostly a disease of the midface, and most patients have some degree of maxillary hypoplasia. It's estimated that a quarter to a third of these patients have enough maxillary hypoplasia to have class 3 malocclusion that will need maxillary advancement. Now, typically the mandible is not affected, and not significantly affected at least. And so unless the mandible is significantly prognathic or asymmetric, in a majority of cases in our center, moving the maxilla is, for the cleft patient, it can be enough. So maxillary advancement, the Le Fort 1 is our workhorse. There's multiple modifications. You've heard about people talk about high Le Fort 1s. The Le Fort 1 is already a natural 2-piece that you can close the alveolar cleft in patients who don't have the alveolar cleft completely fixed. There is a risk of the palate being advanced with the maxillary segment, leading to recurrent VPI. And there's also the risk when you do this in a premature patient before skeletal maturity that you'll risk a recurrence of class 3 malocclusion as the mandible continues to grow till skeletal maturity. So not necessarily a relapse, but an apparent recurrence. This is an example of a patient of mine having just traditional Le Fort 1 plates and screws. You guys know the technique. So let's talk about maxillary distraction. The purported benefits of maxillary distraction are by distracting the whole platform, you're going to move the soft tissue as well as the bone. So especially for a cleft patient who has severe maxillary hypoplasia, this seems to be a good strategy for expanding both the soft tissue and the hard tissue, and also being respectful of the blood supply. It does require a stable platform, so an external distraction osteogenesis would require the skull as your stable platform with a halo, or if you do an internal distraction, the zygomatic maxillary complex becomes your stable platform. Is there less VPI risk, and is there less relapse risk when you do distraction instead of traditional? This is a patient of mine with an external halo, and as you guys know, there's a huge advantage to maxillary advancement. This patient has not had a rhinoplasty yet, but you can see it totally counterclockwise as it advances the nose, totally changing the face of his nose before I even did a rhinoplasty. Here's an example of a patient of mine with internal distractors. This is her the first few weeks after surgery, and she's not in class 2, and she's not in class 1 yet, she's still in class 3. Those are the internal elbows that she's turning, and this is her another week later when she's done turning, and now she's advanced to where she needs to be. And this is her a year later, showing that there's good advancement without significant relapse. When you review the Le Fort 1 distraction osteogenesis literature, one of the interesting questions is what's the cutoff for doing this? And I think that's what the focus of this talk is when to distract a cuff patient. And so these are some of the papers arranged in sequential order. And usually we talk about somewhere between 8 and 10 and 12 millimeters as perhaps a cutoff to decide whether to distract instead of doing traditional. The original Pauly and Figueroa papers from Rush, where they developed a rigid external device halo. The oldest papers did it at every level, but as they later went on, it moved to 8 and moved to 10. Let me move past and show you that one of these papers. And so this paper, they did everyone, even more than 4 millimeters, they used an external distractor showing good results with minimal relapse. This is a paper from UCLA. Kumar Kawamoto was there, and this was a really great comparison of 3 groups. For those less than 10 millimeters, they did traditional Lefort 1, and for those greater than 10 millimeters, they split into traditional Lefort 1 versus internal distraction. And one of the nice things about this is that they really honestly describe, this is from their paper, they really honestly describe the relapse rate and the VPI rate, and you don't usually see that. If you look at the original chart I have, I'm not trying to go backwards, oh, it's the backwards button. But you'll see that most of the outcomes reported in the last column don't always show relapse or VPI. So in the UCLA paper, they showed that in the group 1, which is a traditional Lefort in someone less than 10 millimeters negative overjet, there was no significant relapse and very low VPI rate of 5%. In the middle group, which is the large traditional advancement, there's a fairly large VPI rate of approaching 80%, the black bar, and the relapse rate of 30%. And in the internal distraction osteogenesis group, the VPI rate approached 40%, and the relapse rate approached 70%. And so from this and other papers, I usually tell my patients the chance of getting VPI from a maxillary advancement surgery is probably around 25 to 33% is a reasonable estimate. Then I'm going to share with you another way to do Lefort 1s for large advancements. And at my hospital, Cardinal Glenn Children's Hospital at St. Louis University, we've been using 3D printing like everyone else since the year 2000, using external